Folks, now we'll be discussing an important topic, that is multifetal gestation. So first let's discuss the mechanism of twinning. So we know that the zygote which is formed is basically a two-celled stage. This one is a two-celled stage. Then in the first 0 to 4 days, in the first 4 days, there is further division, and then after this division, there is formation of amniotic cavity, and after the amniotic cavity is formed, there is establishment of the placenta, and accordingly, depending upon the number of days that have passed post fertilization, the type of twin is determined. So in cases of division of the zygote from 0 to 4 days, it is a diamniotic dichorionic. Why? Because the zygote gets divided and the amniotic cavity and the chorionicity, both chorionic cavity and amniotic cavity, both will be separate. So this forms the DATC twins. Now, if the division occurs from 4 to 8 days, then though the amniotic cavity will be 2, the chorion will be same. So this forms diamniotic monochorionic. There will be one chorion only. If the division takes place from 8 to 12 days, it will be a same amnion as well as the same chorion. So it becomes monoamniotic monochorionic. Then further, if it happens so that the division is taking place after 12 days, then it is a conjoined twin. That is, the twins will be joined at one or more places. So among these, the most common variety of twins is a diamniotic monochorionic, this one, in which the chorion is one, but the amniotic cavity, there are two separate amniotic cavities, and the division has taken place at 4 to 8 days. So with this, we come to a classification of twins and how they are formed depending upon the after the fertilization, on which day the division of the zygote is taking place. So there is a rising incidence of multifetal gestation is because of the artificial reproductive technology and ovulation induction. So there are certain risk factors which lead to multifetal gestation. These are a hereditary factor, maternal age, it increases with maternal age, increasing FSH with the age, with increasing parity, with increasing use of oral contraceptive pill, and nutritional status sometimes is associated with is one of the risk factors with for twinning. Then monozygotic twinning is relatively constant and 1:250. However, monozygotic twins is not dependent upon ovulation. It is a constant phenomenon of 1 in every 250 twin pregnancies. So why management differs from a singleton pregnancy? Why a twin pregnancy is more complicated than a singleton pregnancy? So there are complications associated both with the fetus, fetal complications, and there are associated maternal complications. Let's see them one by one. So in the first trimester, first of all, a twin pregnancy has an increased incidence of abortion to the tune of around 7.3% per live birth. That is, there is an increased risk of abortions. Then excessive nausea, vomiting, increased incidence of anemia, hydramnios seen in 12% cases. In the second trimester, the complications that is seen in the mother is preeclampsia and gestational hypertension, gestational diabetes, preterm labor, placental abruption, and pregnancy-induced hypertension. There is also increased chances of placenta previa, acute fatty liver of pregnancy, postpartum hemorrhage, pruritic urticarial papules and plaques of pregnancy, intrahepatic cholestasis of pregnancy, congenital anomalies, and risk of low birth weight. So, there is also an MCQ regarding the incidence of congenital malformations in the twins, which is increased double of a singleton pregnancy. So now let's discuss how do we manage a multiple pregnancy. So the first thing is, as soon as you see it's a twin pregnancy, the first thing you have to do is to determine the chorionicity. This is the first step. In the ultrasound, you have to mention what is the chorionicity of the twin gestation, because this will determine the monitoring for specific complications associated with a monochorionic pregnancy. Also, the nutritional requirements have to be increased in case of twin gestation. The most important thing in the scans done for twin pregnancy is the determination of chorionicity and also establishment of the nuchal translucency of each of the fetus, because that will be the marker of developing further complications. Also, there is one more phenomenon of vanishing twins, which is seen from 9 weeks till 13 weeks period of gestation. And so, when we are doing a dating scan between 11 to 13 plus 6 weeks, we also establish whether there is a phenomenon of vanishing twin associated with the current pregnancy. So, let's see how on the ultrasound the chorionicity is established. This is the figure that you need to see properly. So, there is the layer that you see in blue is basically the amniotic cavity, and this is the chorionic cavity. If you see that there is no intervening chorionic, this one as you see, there is amniotic fluid on both sides and there is a chorionic tissue in between, which is known as the lambda sign. So this lambda sign basically helps us determine the chorionicity if there is a lambda sign, as you see in this figure, this particular figure, that between this blue, which is the amniotic membrane, there is a chorionic intervening layer, and this sign is known as the lambda sign, and this means that this is the chorion also is there in between the two amniotic membranes, so it becomes a diamniotic, dichorionic. So here as we see, there are two amniotic cavities, and if we mark the placental tissue with the blue, you see that it is intervening in between, and this is the lambda sign that we see. So now we will understand the T sign, in which in this figure, if you see, this is the separating amniotic membrane, and you will find that there is no chorionic tissue. The chorionic tissue is going this way. So let me use a different color. This is the chorionic tissue that is going, and this is the separating amniotic membrane. So then this becomes the T sign, in which it means it is a diamniotic monochorionic pregnancy. Clear? Okay. Now, screening and management of fetal complications, chorionicity is of utmost importance. Screening of specific structural anomalies, that is why establishment of NT is important. Screening for aneuploidies on an ultrasound is important, and then there are certain unique complications associated with the chorionicity of the twin pregnancy. So, in cases of dichorionic pregnancy, risk of structural anomaly in each fetus is seen. That is same as that of normal singleton pregnancy, which is 2 to 3%. But in cases of monochorionic pregnancy, when they are sharing the placenta, the risk is as high as 3 times, that is 6%. This is because of the unequal distribution of the cell mass and vascular events in early embryogenesis. So how do we go for a structural anomaly screening? What are the things that we need to keep in mind? These are neural tube defects, brain lesions, facial clefts, gastrointestinal defects, anterior abdominal wall defects, and cardiac anomalies, 2.3% in monochorionic pregnancy. So that is why twinning per se is associated with many congenital structural malformations in the fetus. So, common fetal complications in twin pregnancy is growth discordancy, preterm labor, and single intrauterine fetal demise. So, growth discordancy means that both the twins are growing at different rates and one twin is exceeding the other. Preterm birth occurs per se because of overdistension of the uterus and other factors involved in the maternal fetal HPA axis. Single intrauterine fetal death is another complication, in which case the other twin is also at risk, and so an early delivery, early termination of pregnancy is required if there is single intrauterine fetal demise. Now, preterm birth, what can we do? We can prefer for preterm birth in cases of twin pregnancy, application of prophylactic cerclage or a vaginal progesterone therapy. Both are not significant, which is significant in cases of singleton pregnancy. So what is significant to prevent preterm birth in twin pregnancy is a Arabin cervical pessary. Cervical pessaries work in twin pregnancy. So that is about twinning, its complications. Now we will come with the special complications associated with monochorionic pregnancy, which is the second part of this video. So, unique fetal complications associated with monochorionic twins. The first thing is twin-twin transfusion syndrome, then twin anemia polycythemia sequence, then twin reversed arterial perfusion sequence, the TRAP sequence, and selective intrauterine growth restriction. So you just need to know the name of each and few things about twin-twin transfusion syndrome for your MCQ purpose. First of all, make a concept that these are all associated with monochorionic twins per se. So basically, complications of vascular type is, most of these are because of the vascular complications. So there is in the monochorionic placenta, there is vascular anastomosis to the tune of around 96%. So twin-twin transfusion syndrome and twin reversed arterial perfusion sequence, I'll explain them each. Twin anemia polycythemia sequence. So first let's come to twin-twin transfusion syndrome. This is seen in 10 to 15% cases of monochorionic twins. It will usually present from 16 to 26 weeks period of gestation. So basically what is happening is, there is on the deep arteriovenous levels, there is unidirectional unbalanced flow, so that one twin becomes the donor and the other twin becomes the recipient. So this is the donor twin and this is the recipient twin. So what is happening from the donor twin? The blood is being specifically going into the recipient twin. So this baby has anemia, this baby has polycythemia. This baby is having a reduced cardiac output, this baby is having a high cardiac output. This baby is having less of amniotic fluid surrounding itself. This baby has polyamnios surrounding itself. So this forms the sequence of TTTS syndrome. So the donor twin is anemic and growth restricted. The recipient twin is polycythemic, hydramnionic because of the increased cardiac output, plethoric, there is hyperbilirubinemia because of polycythemia, and features of vaso-occlusion because of polycythemia per se. So, in TTTS, there is something called a Quintero staging. Stage 1 there is an oli-poly sequence. That is, in one twin there will be oligoamnios, which is the donor twin, and in the recipient twin there will be polyamnios. In the second stage, there is no bladder shadow visible in the donor twin. In the donor bladder, there will be no bladder, and Doppler, however, will be normal. In stage 3, there will be Doppler changes in the umbilical artery and the ductus venosus or the umbilical vein of both the donor as well as the recipient twin. In stage 4, there is ascites or frank hydrops in either of the twin. So this forms the Quintero. So that is the Quintero staging, and depending upon the stage of the disease, and in stage 5, there will be demise of either of the two. So that is why this Quintero staging is basically done to determine as and when do we need to intervene depending upon the stage of the disease and the gestational age. Then TTTS management, basically if there is an early diagnosis, we go on for monitoring right from 16 weeks period of gestation. Whenever we see there is an oligopolyamnios sequence and other findings of TTTS syndrome rising up, we can go for intervention either with amnioreduction, septostomy or laser therapy. Now, in such cases, a higher center referral has to be done. It is the work of an experienced obstetrician who can deal with laser ablation of the anastomotic levels at the level of the deep arteriovenous levels. If there is laser coagulation of vessels, then the prognosis becomes much better in cases of twin transfusion syndrome. So this is all you need to know about twin transfusion syndrome. Now let's come to twin anemia polycythemia sequence. In this condition, there is significant hemoglobin differences between the donor and the recipient twins without the discrepancy in the amniotic fluid. That is, there will be no oli-poly sequence. However, we will find that there are Doppler changes. Spontaneous TAPS usually occurs after 26 weeks, and iatrogenic TAPS develops within 5 weeks of laser treatment. In this condition, we have to monitor the middle cerebral artery peak systolic volume, and in case if one of the baby has severe anemia, we have to go for an intrauterine transfusion. So, twin anemia polycythemia sequence can be both spontaneous and iatrogenic after laser therapy. And the confirmatory diagnosis comes in the postnatal period when the intertwin hemoglobin difference is 8 grams or more. Then let's come to twin reversed arterial perfusion. Here it is also known as acardiac twin. So it occurs in 1% of the monochorionic twins. The donor twin is morphologically normal, hydramnionic. There is cardiomegaly, pericardial and pleural effusions, ascites and tricuspid regurgitation. However, the recipient twin lacks the heart and is a parasite. So this is known as twin reversed arterial perfusion sequence. If the size of the recipient is more than 70% that of donor, chances of cardiac failure is high in the donor twin. So basically what is happening, let me explain you. So there is a twin which is the donor. From here, the vessels are anastomotic with the vessels of the recipient twin, and the blood flow to the recipient twin is just going into the lower limbs of the fetus without any flow into the upper limb. That is, beyond the thorax, there is no blood flow, because of which the recipient twin is acardiac. That is, doesn't have a heart. The pumping action in the recipient twin is also controlled by the donor twin, because of which there is a high output cardiac failure in the donor twin, and the recipient twin is acardiac. Although the lower limbs and the lower part of the body is well developed, the upper part is morphologically abnormal. So that is what is happening. That is twin arterial perfusion trap sequence. Twin reversed arterial perfusion sequence. So this is one of the complications associated with the monochorionic pregnancy because of vascular anastomosis. So this is the fetus. This is an acardiac, acephalous fetus. Only the lower limb is developed. The upper part of the body is completely non-developed. And this is the acardiac myelocephalus. That is, a little bit of the head is formed. Acardiac amorphous, failure of any recognizable structural form. So that is the trap sequence. So in trap sequence, you have to go for a cesarean section. Normal delivery is normally not allowed. Let's understand when is the labor and delivery timing according to chorionicity of the twins. So a DA-DC twin has to be delivered by 36 to 37 weeks. A DA-MC twins according to the ACOG guideline. According to ACOG guideline, a DA-MC twin at 34 to 38 weeks. RCOG says 36 to 37 weeks and COG says 37 weeks. That is, you need to remember a DA-DC twin can still be induced at 37 to 38 weeks. DA-MC has to be delivered by 36 to 37 weeks and DA-MC at 32 weeks. MAMC has to be delivered by 32 weeks. So you need to remember this 32 weeks. You need to remember this 7 weeks and this 36 weeks. This 3 is the information that you need to know. The only thing that you need to understand is in twin pregnancy, if you go beyond 38 weeks, the chances of complication is very high. In case of more than 2 fetuses that is if it's a triplet, quadruple and others, you have to go for a cesarean sections. In monochorionic pregnancy, monoamniotic, monochorionic, it is always a cesarean section has to be done. A cesarean section is also indicated in twins if if the first twin is a vertex, we can go for a normal delivery provided we have expertise of breech extraction or delivery of a transverse lie. If we have those expertise, we can go for a normal delivery. Otherwise, we can go for a cesarean section in case even if the first twin is vertex presentation. But if it is irrespective of any other presentation, if it's not vertex presentation for the first twin, an elective cesarean section has to be done. So, what are the things? When do we go for a normal delivery in twins? If the first is cephalic and we have an expertise of delivering the second twin in whatever position the second twin is, and if the first is non-vertex, we have to go for a cesarean section, and and it requires a senior obstetrician for management of management of delivery of twin pregnancy. So what are the indications of elective cesarean sections? If it is a monochorionic, monoamniotic, conjoined twins and higher order gestation. So what are the specific points that we have to keep in mind during a twin gestation is that we must have a proper training of how to do breech extraction, internal podalic version, and delivery in cases of transverse lie, and also emergency cesarean section for delivery of second twin. So, indication of internal podalic version is only exclusive to the second stage of labor in conjunction with breech extraction to effective delivery of the second twin with a persistent transverse or oblique line. So, only place where an internal podalic version can be done in obstetrics in recent era is a twin delivery for the second twin. So in third stage, we have to take care of active management of third stage of labor. Oxytocin infusion has to be continued and be prepared to deal with atonic PPH. Postpartum complications, PPH, wound breakdown and other complications of puppedium that we have discussed is still there in twin pregnancy. Now there is something called selective fetal reduction and termination. Selective fetal reduction is nowadays a common procedure because of the ART. The number of embryos that is transferred or implanted into the uterus will determine how many embryos are actually ending up with live pregnancies. So in certain conditions, if it's more than 2 pregnancies, or even if 2 pregnancy and the mother wants a singleton pregnancy, till 14 weeks of gestation, we can go for a selective fetal reduction and can reduce the twins to singleton or a higher order pregnancy into a twin gestation. This is known as selective fetal reduction. Selective fetal termination means that if one of the twin has certain congenital malformation or some aneuploidies associated, then that fetus has to be terminated, and that is known as selective fetal termination. So that is the difference between the two. So with this, we come to an end of discussion on twin pregnancy or multifetal gestation. Thank you so much.